Okay, so the committee has selected 3 speakers to provide perspectives from different sectors working on environment and environmental health issues in a range of ways. Our first speaker is Rich Fuller. Rich Fuller is the founder and president of Pure Earth, which is a nonprofit dedicated to reducing pollution exposure for people in low and middle income countries. Pure Earth has done tremendous amount of work in reducing exposure to contaminated sites. Rich is also the head of the Global Alliance on Health and Pollution. This is a stakeholder group that is composed of the World Bank, the Asian Development Bank, UNEP, UNIDO, the governments of 25 countries. And most recently, he has co-chaired an important Lancet Commission report on pollution and health. So I give you Rich Fuller.
Thanks, Maureen, and it's great to be here. I do appreciate it. Jessica, how do I work the back and forth here? Lovely, thank you so much. I must say it's wonderful to see the National Academies consider this topic and bring it to public attention. This is exactly the sort of thing that we've been dreaming about for the last decade and a half. If I can give you a little background and thank Maureen very much for her introduction. Our work around the world since 1999 has focused on places that are acutely toxic and have got large degrees of mortality and morbidity because of their exposure to pesticides, heavy metals, mercury, chromium, and all the rest in different places. We've been responsible for creating an inventory of places that often are as bad as Love Canal. In 50 countries, there's 4,500 locations in this database so far. And we have also been helping countries to begin to understand how bad pollution is in their countries. And one of the things we did in that respect, as Maureen kindly pointed out, was to create this particular group, the Global Alliance on Health and Pollution. And this group was started 8 years ago with founding members, the European Commission, World Bank, and the UN agencies, and has since gone out and brought in 25 countries as members who are concerned about pollution and the impact on its citizenry. The first thing we did as a group was make sure pollution was adequately represented in the SDGs. And prior to our involvement, it was there not in all of its aspects. So that was a significant piece of work to do that. An awful lot of time spent at the UN building handing out pieces of paper and having delegates call their delegates in the meetings and stand up and make the right pitch. It took a lot of work. More important, after that, we convened the Lancet report on health and pollution. And that Lancet report, there are several authors here, Pat Bracey, one, and Maureen, of course. And so what I'd like to do now, if this will work, yes, is give you some of the results from that analysis in the Lancet report, globally and a little bit of domestic review as well. And then show you the experience of setting up this global alliance, because it has some similarity to what you're looking to do here with the National Academies. I also want to talk to you about the main mechanism we think is appropriate to focus the priorities for interventions and work domestically and internationally. So let me begin by showing you some of the data regarding pollution from the Lancet report. And I always like to start out this by comparing deaths from pollution to other things we know and are concerned about globally. First, there's Ebola. You can't actually see it, it's too small. War and murder. This is millions of deaths in 2015, by the way. The data set comes from Institute of Health Metrics and Evaluation. It's backed up by a similar data set from WHO. The numbers are really quite comparable. War and murder was about 200,000 deaths in 2015. That includes all murder globally, by the way, and all acts of war. Here's road accidents, about 1.3 million deaths that year. Malnutrition, the worst piece of the development problem. Drugs and alcohol, AIDS, malaria, and tuberculosis, where we spend upward of $25 billion a year on that particular problem. Sodium has a big impact. This is diets high in sodium. Tobacco, that we've always considered to be the largest public health problem. And here's pollution. It overshadows them all. It's 9 million deaths a year. 1 in 6 deaths in the world is premature because of exposure to toxics of some sort. And this problem is really a problem of development. It's mostly showing up in low and middle income countries. So we've color-coded this map to show you the amount of death from pollution in different countries. And the deep red countries, including India, 1 in 4 deaths are occurring there because of pollution. By the way, of that 9 million, about 6 million is air pollution, 3 million indoor air, and 3 million outdoor air. About 1.5 million comes from water and sanitation issues. And the balance, about another 1.5 million, comes from chemicals and occupational exposures to different kinds of pollutants. So 92% of these deaths are overseas. The US, I'll show you a bit more data on that later on. About 5% of deaths in the US are attributable to toxic exposures. Here is the US actually in a bit more detail. There were 157,000 deaths in the US. I've compared them to the right with a lot of other major public health issues in the US: tobacco, alcohol, sodium, road accidents, conflict, and HIV. You can see air pollution was responsible for almost 100,000 of the 157,000 deaths in the US. Lead, a small percentage. And occupational, most of it, of course, being asbestos, quite a substantial number of deaths as well. One of the things we did globally, stepping again back into the global sphere, was look at the differences of pollution over time, and traditional pollution in low-income countries especially, that which is associated with abject poverty, indoor cook stoves, sanitation, poor sanitation. That's been improving over time as the world's economies have been improving as well. So the orange line shows deaths, again, reducing through the period of study. Modern pollution, industrialization, urbanization, outdoor air, chemicals, and the like. This is where we don't put much attention, and that number has been increasing over time. And this is where I think we ought to be focusing domestically here, of course, as well. Switching to look at this in another way, this now is DALYs, Disability Adjusted Life Years. It's another metric used by health experts. It's a year of life that's lost because you've either died prematurely before your time, or you're unable to work because you're sick. Now, this at the bottom, the scale is the age at which the DALY occurs, and the left is how many DALYs occur from all types of pollution globally. And you can see post-neonatal and kids between 1 and 5, there's a great deal of impact. And this occurs because of infectious disease, usually from traditional kinds of pollution. But the one that worries me more is this gap, this bump here in the 50s and 60s. And these are non-communicable diseases that are affecting people later in life with cancer and cardiovascular disease. And in fact, when you look at the overall scope of disease from pollution, 70% of the deaths are non-communicable diseases. And this poses a problem because NCDs, cardiovascular cancer, and pollution exposures are separated by a long period of time. And making the argument that you were exposed at some point to particulates or lead or wherever else, that then will cause a reduction in your life in the future, that's complicated and difficult. But we have done it successfully with smoking, for example, with tobacco. I think we can make this for the rest of the pollution agenda as well. We must also remember that IHME and WHO's data sets are very preliminary. They're in very early stages of maturity. And there are enormous gaps in this overall scope of work. We, for example, are not correctly measuring all of the chemicals and soil exposures that are out there in the world. We, in fact, only are measuring from environmental exposures one toxin, which is lead. the others, pesticides, mercury, PCBs, endocrine disruptors, all the rest of them, are just not yet counted adequately. And this is, I think, a big deal for the national academies. This is an area where the national academies can make an enormous impact by assisting in increasing and enhancing the GBD analysis for all of this. In order to make this point, we've created this term, the pollutome. One needs to have a new ohm every now and then. Here, the pollutome kind of shows, here is at the first level, the ones where we are counting, and we have been able to include their impact in the Lancet report. But underneath, we know of a lot of health impacts that are already being caused by different kinds of toxics that have not yet been quantified at a global or a national level sufficient to be able to include them in these analyses. That number now needs to be worked up and increased. For example, we just got notification of particulates having an impact on diabetes rates. There are similar issues related to lead that I'll show you in a second as well. None of these have yet been included and now need to be included. But we also know there are an awful lot of suspect issues out there where environmental mechanisms have an impact on health that we haven't really even begun to study and don't really know about it. So the pollutome needs to look at all of these issues and work forward with all of these issues. Thanks to the amazing Maureen Cropper, thank you Maureen, we also use this data set to analyze the economic costs of pollution. And the number I like most is that 2% of GDP is lost in low and middle income countries because of the productivity losses from either dying before the end of your work life or from being sick. 2%, that's an enormous GDP number that any country should be concerned about. And where we had data sets, and there was very, very little of it, where we could quantify the health impact in terms of medical costs, it was at least 7% of medical costs in these countries. And then we all know, of course, the willingness to pay methodology, which looks at an economic number based on people's assessment of how much they're willing to pay to live a year longer. This number comes in just enormous, at more than $4 trillion a year of cost. So this is a problem of an enormous scale, not only in terms of health, but in terms of economic impact as well. And there are the main findings of the Lancet Commission. I would recommend this to all of you to look at. The executive summary is particularly easy to read. And of course, we must thank, amongst others, Linda, NIEHS provided some support to this. USAID was absolutely superb, the European Commission, and then quite a lot of European agencies helped to fund this work. So, let me give you some background now, having done that work with the Global Alliance, where that organization is moving forward. And perhaps this can serve as some basis for the considerations that are going on here. We're focusing in two ways. One is in countries to help them to work out how to solve pollution problems. And secondly, to increase the advocacy work related to pollution and health globally. And the country work is very interesting. We're doing program work right now in 6 countries to test out this particular process we're calling the Health and Pollution Action Plan. And what we do here is we'll bring GAP membership, people like World Bank and the UN agencies, together with all of the relevant country agencies in a particular country. That's Ministry of Health and Environment, Transport, Finance, Tourism, Agriculture, Industry. Bring them all together at a senior level and sit down and look at their death figures or their disability figures from pollution in that country. And usually they're stunned. They just are not aware that pollution is having such an enormous impact on health and economic growth in their country. It takes a little while for them to come to bear with all of that, but then the work drills down into the specific high-impact problems that are happening in their own country. And we review then what activities are currently going on to solve those problems and whether they're sufficient. And if they're not considered sufficient by this group, what would be the next logical step to be able to reduce death and disease? from these problems. And from that, a whole series of programs are designed, usually 2 or 3 in each country. For example, in Thailand, they've done a great job on air quality in Bangkok, and the air numbers and deaths have reduced substantially. But in the northern part of Thailand, twice a year, they have enormous amounts of particulates from crop burning, and it's burning of corn residues. And if you've ever been to Chiang Mai in the season, you cannot drive down the streets. It's so dense, and the mortality from this is really large. 0 programs from the Thai government. Now they'll begin to design and implement some programs related to that. GAP also is doing advocacy work. We have a series of committees, some research committees that's beginning a group called the Global Pollution Observatory, based out of Boston College and Harvard School of Public Health. The GPO, I love the initials, will aggregate data from all types of pollution, air, water, soil, and occupational. And it'll aggregate exposure data and then public health impact from that exposure, and try to do this with the strongest and most robust data sets we possibly can. There are other committees doing other work, especially related to communications and policy as well. Now, from all of this work, we've learned a few key lessons. For us, it's been important that the Global Alliance responds to our members' needs, and that's been the countries who are most affected. So we spent a lot of time dealing with that. But what we've also been very committed to do is to focus on solutions, not only the advocacy, the conversations, the policy work, but what are the pragmatic solutions that will reduce the burden of disease? Largest cause of death, how do we get it to come down? Country by country, we work out what programs need to happen, and we help them to implement it. And that is beginning to bear some fruit. Also, we've also found, this is true not only in countries, but amongst the development community, there is almost no funding available for dealing with this work within overseas development budgets. Over the last decade, I have knocked on every single major foundation's door, looking to see if they'll put environment and health as an issue within their priorities. The same for all of the development agencies, the European Commission, the Sweden, Norway, Japan, and all the rest of them. None of them put this as a priority. They'll deal with plastics, they'll deal with biodiversity, they'll deal with climate change, of course. Environment and health is a new upcoming idea that no one yet has put into their development policies. So finding support for this within the development community is extremely difficult, and partly because of that, the countries themselves have not made it a priority in their own development processes. So it's an uphill fight, one worthy, of course, because there's so much to gain from doing it. Now, let me step back and go back to the US. I want to go back to this chart of the data from IHME, now looking at 2016 because that data has come out more recently. Here are the some tobacco, alcohol, and drug road injuries numbers to be able to start with. But let me look at some of the environmental risk factors that are out there. There's radon. Particulates is a significant issue. Here's asbestos, and here's lead. So these are the bigger numbers currently in the data set related to environmental exposures in the US. And that adds up to that 150-odd thousand deaths a year that I mentioned at the beginning. But lead is interesting. Just a few months ago, Bruce Lanphier from Simon Fraser University published a paper in Lancet that looked at the NHANES data set, and for the first time calculated the impact on cardiovascular disease for old people, for us, people our age, from low levels of lead exposure. And he did this and found, in fact, that lead causes as much cardiovascular disease as smoking does. And the processes here for this particular study are backed up by a couple of other similar studies. And this is, I think, the turning point for lead coming back and becoming a resurgent issue in our lives and in our concerns. Because lead is not just an issue for children and developmental disabilities. It's an issue for us old folks too. And even low levels of exposure, and I mean 1 and 2 micrograms per deciliter, earlier on in life, impact cardiovascular disease, like smoking a packet of cigarettes a day, to that sort of level. What worries me, of course, more is that the average in the US is only 1 microgram per deciliter. WHO and CDC set an action threshold of 5 micrograms per deciliter. But our work overseas, we don't have a single country where the average population is under 5 micrograms. More likely, the urban areas are at 7 micrograms and the rural areas are at 15 or 20 micrograms. So there are very, very high lead exposures overseas that are not coming from lead in gasoline, because all of that has been banned since the 80s and 90s. Instead, it's coming from lead in pottery, from battery recycling and e-waste, some from paint, although less than you'd think. And lead, I think, is an issue that globally, if we do use Bruce's methodology to calculate, it probably would be causing as much death and disability as outdoor air pollution. And it will take a few years for the science to catch up, but I think that's where we're heading for this in this particular issue. So just stepping back for a second, the death numbers are certainly, I think, the basis for how one should prioritize. But as we well know, there's more to risk than just the hard science behind it. We really like the work of Peter Sandman, and I'm sure many of you are very familiar with, who talks about risk as being the science, the reality, plus the outrage. And for this, of course, we need to be considering environmental emergencies as they're occurring. And this obviously also includes lead. If we're thinking about lead as a priority, Flint, in terms of gross environmental health impact, it's not an enormous impact. It's certainly substantial, but not enormous. But it's only the tip of the iceberg. There's so much more lead problems going on in the US. There's problems in Los Angeles with an old battery recycler that's contaminated large neighborhoods. Philadelphia, some of the waste sites are starting to leak and lead's coming out. The capping has been not doing as well as it should. And one other area that I want to draw attention to. I talked about how bad toxics are broadly overseas, with very high levels of all kinds of heavy metals and pesticides and other things internationally. So much of the world comes back to the US in the form of trade and foodstuffs, and that stuff comes back and impacts us as well. And we're in the middle of writing a report that looks at this lack of boundaries globally in the way that toxins move around the world. And some of these statistics are, frankly, quite disturbing. 29% of particulate matter in San Francisco is coming from the coal fields in China, floating all the way across the Pacific, and then having an impact in San Francisco. We looked at FDA reports for fish and similar ones for fruit and vegetables. They're only able to test a minute amount of the material that's imported. But of the amount that they did test, they rejected 9% of it. These things, I think, are issues we need to be concerned about, not just looking at sources in the domestic realm. And so if I look at the recommendations, what I would suggest this august body could do moving forward. First, I would say, focus on global burden of disease analyses. Look to find out where the big problems are, because you want to take these very scarce resources that are available right now and use them to solve the biggest problems. Let's put our money where we can save the most lives and look after the most kids. That's the first thing. And I think when we do that, we ought to make sure we're looking at exposures from all of the different sources that are coming in there, and that includes what's happening internationally. And if we're dealing with solutions to these issues, yes, domestically these are complex and involved, but the international solutions often are about providing development assistance to shut down that factory that's poisoning the storage of avocados next to it. And those avocados then would get shipped to the US and poison our kids. So those sort of issues and that kind of approach, I think, will have the most impact for us here domestically as well. And I think of the world and the livable world as having 3 pillars: climate change, biodiversity, and pollution. And we do some effort in biodiversity and climate change. but we've forgotten about dealing with pollution. And I think if we can think of the world with those three things as co-requirements to make our future safe and our kids safe, then we'll all be in a much better place. So, I'm very happy to take questions about all of this, and thank you very much. Hi.
Hi, I'm Ellen Silvergill from Johns Hopkins, and I'm working on ILO. Yeah, no excuse. I'm working on a project with the ILO WHO to look at the global burden of disease related to occupational exposures, including an attempt to do prevalence of exposure. And my concern, while I endorse everything you said, and certainly the idea of looking at the worst first is a good principle, let me be very frank. Our data are so bad that I'm not sure you should do that. Maybe you should look at the cases that are strongest and where we also have good notions of interventions. But I think our desire of doing worst first when we have absolutely no idea of what's happening, even for lead, as you know, might be counterproductive. It's just a thought.
I take your point, and the lack of data is really disconcerting. There are, however, reasonably simple ways of moving that data threshold reasonably high with not a lot of work. I think about lead, for example, doing baseline analyses by looking at existing reports and looking at their own blood level testing from existing studies can go part of the way, but you can also go in and look at a few thousand kids and get some sense of where a baseline number for lead might be in a non-occupational sense if you want to. The other thing that I think is... You can do this.
There are exposures. I'd really be quite concerned.
I can tell you one example in Mexico. We've recently funded ENSENOD, which is the national health study in Mexico, to go out and include blood lead testing for about 15,000 people in Mexico. And that is not at a bias. This is done just as a random kind of selection. And that will give us a baseline, I think, in Mexico on a regional basis. The other thing I think you can do is you can look at source apportionment analyses. So you could say, here is the toxin that I am concerned about. Let's go out and work out where it's coming from. And those sort of studies can be very useful as well. So you're right, this is a very early stage issue, but a small amount of investment can help to bridge that lack of knowledge and bring it into a place that's much more successful. So.
Yes. Good morning, Richard. I'm Craig Postwaite. I'm a member of the Board of Environmental Studies and Toxicology here at the Academy. We've been heavily involved with this initiative and trying to help define what role it will fill. I'd like to thank you, first of all, for your great work internationally that you've accomplished. I was not aware of such a forum and group of people with these 25 nations and 65 NGOs. You've accomplished a lot. So in terms of the function as we define the Environmental Health Initiative, you've given us some recommendations for us to consider. But the one you did not mention specifically on that list was advocacy. And as you mentioned, it's hard to get countries to make environmental health a priority. And I would say that even for this country to some extent. Do you see a role for the Academy as maybe stepping into that area? I see you have interactions with the UN and the WHO already, but I would be interested in what role specifically that the Academy could help with this advocacy.
I think if you could bring the Academy into that position, it would be enormously influential. The UN agencies are somewhat restricted from their ability and their membership to be able to advocate, especially with respect to funding and overseas development assistance requirements. I think if the Academy chose to take on some of that role, it would be extremely influential within the UN system and within the US institutions that have traditionally provided some support into those particular roles. I would welcome that with open arms and be happy to give as much support and advice and networks as I possibly could in that area.
Hi, I'm T. Gadati. As you know, the Sustainable Development Goals contain health goals as well, but small number, and they don't really relate much to the economic development goals in the SDGs. In this country, sustainability has really become a mainstream management effort with software, with management systems to do that for major corporations. My concern is that as sustainable development, both for developed and developing economies, becomes a reality and moves forward, are we missing an opportunity to build health gains into the new sustainable economies that we are building, and what can we do to ensure that measures are put into place that will themselves be sustainable and will lock in health gains and reductions in health risks for generations?
It's interesting how the Sustainable Development Goals developed, and the concept overall has got a lot of support within the UN agencies, and obviously it makes a lot of sense in terms of where we want to go, for the world in general. When it boils down to the rubber on the road, though, the detail in this is about what's the specific measurable impacted problem that needs to be solved. And rather than go at this from a Sustainable Development Goal initiative, I like to deal with this from a public health perspective. So if we can look at where are the most significant public health impacts globally and look at the engineering type solution. I was thrilled to hear Daniel's conversation about engineering having a lot of the solutions to all this. I think we're going to go a long way. I'm going to leave the SDG conversations and all of those sort of issues to the policy folk who are good at that. But really where we want to focus is solving the problem, bringing this number down, and helping the health of the kids and people on the planet.
Linda Birnbaum. Hey, Richard. I think what the Lancet Commission has done has been phenomenal, and it is just very much a start, because I think much of the focus for now has been on mortality, a little bit on the dailies. We really need to look on the long-term impacts other than mortality. I mean, Leo Trasande from NYU has done estimates it's over $1 trillion a year cost of the IQ impacts of lead. Nobody has factored that kind of thing of cost. And at least in the environment we're all living in now, at least the political environment, it's cost that counts and it's dollars that count. And I would say that the other really, really big challenge that we in this group have, and you have also, is a communications challenge.
Exactly.
How to make the impacts that we are understandable and something that people can really feel. It can't be abstract. It has to be concrete. So concrete examples.
Right. And conversations with the World Bank also reflect this too, Linda. They're looking for, as this agenda moves forward, making sure that there's clear ideas of what the solutions are and how they work that are put up front and in front of the conversation as well. So we can say, here is something that has this kind of economic impact, this kind of health impact, and here's the solution and how much it would cost and how it would work and what its chance of success would be. I think those things need to be all embedded in the conversation at the very beginning of it so that people can get the sense of how it goes.
Thank you very, very much.